some views about cardiotocography in labor, the pathophysiology and the evidence. First of all, let me thank the POGS new society, which is taking great initiatives, Dr. Kunjmuddin and Dr. Mitra Saxena for this invitation to be with all of you today. So, as we know, labor is the first, shortest and most dangerous journey of a human being. And the dangers lie with the mother as well as the baby. Stillbirths still happen. And in spite of all the great advances that we have made in obstetrics, a number of stillbirths are still attributable to events that occur in labor. Half the stillbirths are related to events in labor. And this is because of the quality of care during the labor process. If we look at the reasons for fetal neurological injury, of course, there are metabolic problems, fetal abnormalities, and infection. But hypoxia and asphyxia also play a major role. So if we ask ourselves, is fetal monitoring worthwhile? Then the obvious answer is yes, because intrapartum asphyxia contributes to 20% of fetuses who are born in poor shape, about 10% of cerebral palsies, and 3% of fetal loss in singleton pregnancies at term is because of intrapartum asphyxia. That's a fairly significant contribution. It's also important to acknowledge that a large proportion of these events will happen in women who are thought to be otherwise low risk. So these are not the IUGRs, these are not the hypertensives, these are not the diabetics whom you're giving a trial of labor. They are just plain simple pregnancy antenatal cared for who are going to land up with these problems. Now, we all face stress, and there is a certain degree of stress which is a part of day-to-day life. In fact, psychologists and psychiatrists say that some amount of stress is important to give your best performance, but it has an inverted U relationship. So stress is good until it brings you to your optimal performance. But after that, stress results in higher pressures, higher workloads, and deteriorating performance. The same is true for the fetus as well. So in order to find and distinguish between fetal stress and fetal distress, we need a monitoring method. And that ideal method should identify fetal hypoxia before there is fetal damage or asphyxia. That means it should have a good sensitivity. It should have very few false positive results. That means it should have good specificity, and therefore we'll not do unnecessary obstetric interventions. And of course, the method should be feasible, affordable, acceptable, and accurate. So what do all of us want? We want Sundar, Sasta, Tikau. And the same goes for electronic fetal heart monitoring also. Of course, it's not the ideal method, but it comes close to fulfilling some of these criteria. Let's look at the physiological basis of fetal heart rate monitoring. And the basic principle is that it is governed by the autonomic nervous system. This gets affected early in states of hypoxia, and the changes in this condition are going to be reflected instantaneously and momentarily. Now, both these words are important. Instantaneously means as soon as there are some changes in the physiology, the heart rate will show some changes. It is not like, say, amniotic fluid index, which will change a week or 10 days after the insult. And momentarily means the impact of that condition will last for a short time and allow for the recovery. So both these words are important in understanding the fetal heart rate physiology. The changes are instantaneous and momentary, and these are brought about by changes in the cerebrovascular circulation, reflexes, the baroreceptor and chemoreceptor reflexes, and changes in the fetal blood pressure. What are the parameters that we need to study? This is very beautifully illustrated by this acronym, Dr. C. Bravado. And what does it stand for? DR is defined risk, whether it's a low or a high risk. C is contractions. BR stands for baseline heart rate. V, variability, accelerations, and decelerations. So all this has to be put together in giving an overall assessment. This is a classification of the parameters, and this comes from the FIGO consensus guidelines. These parameters have gone through a number of changes and refinements. Today, what we look at is a baseline between 110 and 160, variability 5 to 25, no repetitive decelerations, and there should be some accelerations to show that the fetus is in good health. Now, when we look at baseline heart rate, the basal rate should be 110 to 160 beats per minute. And this is governed by the sinoatrial node in the heart and the autonomic nervous system. What does stress do? It induces a flight or fight response. Whenever we are in trouble, we'll either flee from that site or we'll fight the situation. So this is brought about by the catecholamine surge, which induces tachycardia. After a certain point, there is a depletion of the reserves, the heart slows down, the myocardial contractility reduces, and this is the point where stress changes to distress, and we see bradycardias in the form of prolonged decelerations, and it could be terminal if no action is taken. A number of things will change the baseline fetal heart rate. So fetal tachycardias most commonly are because of a high maternal pulse rate, like in situations where the woman has fever, anemia, hyperthyroidism, infections, certain drugs. All these will raise the fetal heart rate. And what about fetal bradycardia? Exactly the same features, but in the reverse. If the mother has bradycardia or is on certain drugs which are going to reduce the heart rate, then you're going to get bradycardias. It could also be because of structural cardiac defects or arrhythmias and viral infections like cytomegalovirus. Variability is a concept which we need to appreciate as a force of nature. There's no healthy system in nature which is perfectly constant. It just can't happen. And variability is innate to every natural healthy parameter. If you look at heart rate, if you look at respiratory rate, you look at the ST interval, it's never going to be exactly the same from moment to moment. When nature loses this variability and it just remains static, that's a departure from the normal state. So fetal heart rate variability, you have to understand, is a band. So between 5 to 25 beats per minute, there is going to constantly be a fine interplay of the sympathetic and parasympathetic components of the autonomic nervous system, which results this constant up and down of the basal heart rate. If there is a reduced variability, that's called a silent pattern, and if it's increased, it's called a saltatory pattern. Now, the reduced one is the one which I would usually worry about. Physiologically, this can happen when the fetus is asleep, but it can also happen when the woman is on certain medications. And here, I would like to draw your attention to drugs like alpha-methyl dopa, which was a very popular drug that we used for hypertension. The premature fetus, the one with congenital anomalies or anemia, and the one who has arrhythmia will also show a reduced fetal heart rate variability. But please remember, when you see less fetal heart rate variability, your first thought should be hypoxia. Why are there accelerations in the fetal heart rate? And this goes back to first year medicine physiology. Cardiac output is a product of heart rate and stroke volume. So whenever the fetus moves, there is a generation of catecholamines, and this transiently raises the cardiac output, and this acceleration which is there represents a healthy adaptation. Now, there are going to be sleep and quiet epochs, and these are termed together as cycling. So you may not get an acceleration while the baby is asleep in the womb. And this can be physiological for up to 90 to 120 minutes. It's fine. But beyond that, if you take a continuous pattern and still there are no accelerations, then it becomes a cause for worry. Now let's look at the pathophysiology, and the features which first come to our mind are the decelerations. So let's start with early decelerations. These are a result of compression of the fetal head in advanced labor. The woman is 8-9 centimeters dilated, the station is 0 or below that, and there is pressure on the fetal head, which results in a change in the cerebral blood flow. Vagal stimulation is there, and therefore there is a reduction in the fetal heart rate. This reduction is exactly corresponding to the contraction. As long as the contraction is there, there is a reduction in the fetal heart rate. It is not because of hypoxia. It's important to time the contraction to understand that this is an early deceleration, but be wary of the pattern of early decelerations, which an unengaged head might give you, or it's an early labor. This might be deceptive. Early decelerations might turn into prolonged decelerations or bradycardia when there are hypercontractile states. Variable decelerations have a very beautiful and very well elucidated pathophysiology. There is cord compression. Now, this is physiological. There is going to be some cord compression when the woman is in labor. That's a natural part of labor. So when there is cord compression, initially the umbilical vein, which is the thin-walled vessel, is going to get compressed. This reduces the fetal venous return. The transient reduction in the fetal cardiac output and blood pressure stimulates the baroreceptors, and this transient reflex of raising the heart rate is seen as shoulder. So before the heart rate goes down, as I'm trying to point out with this arrow, there is a small increase and then it will reduce. Now, why is this reduction there? That's because after the umbilical vein has been compressed, the thicker walled artery is going to get compressed. This results in an abrupt rise in the fetal peripheral resistance and blood pressure. Again, there's a baroreceptor stimulation in the other direction, reflex parasympathetic outflow, and an abrupt slowing of the fetal heart rate is there. The exact opposite happens when the compression is released. The artery recovers first, the fetal heart rate rises, it goes a little above the baseline, and then it comes back down to the basal rate. Now, it's important to understand that all variable decelerations are not abnormal, but there are some which you have to look out for when there is a prolonged cord compression, prolonged periods of interruption of the oxygenation, or there are repeated cord compressions resulting in a chronic lack of oxygen to the fetus. And these patterns will be spoken about by Dr. Umaram in the next lecture. Late decelerations are the ones which one needs to really worry about. They are a result of either a reduction in the fetal blood flow, of hypovolemia of the fetus, or there is hypoxia. And the mechanism of late decelerations is the stimulation of the chemoreceptors. There is a reflex sympathetic outflow, there is peripheral vasoconstriction, there is an increase in the blood pressure, baroreceptor stimulation occurs. Gradually, the heart rate slows, and this is going to look like a slow decline and a slow recovery. This happens after, generally after the uterine contraction has occurred. What we also see with the onset of late decelerations is the fetal adaptation and the rise in the baseline towards a higher rate and the loss of variability. So this is what the pattern will look like. You will see fetal pattern recognitions later on in this program as well. What are the advances that we have seen in electronic fetal heart rate monitoring? Computerized reading, where the human element is taken care of. So there are lesser errors. Electronic storage is allowed, and now we are used to doing everything remotely. So there is telemedicine, which allows remote sensors, transmitters, and even ambulation is possible. How good is a test in clinical practice? It depends on the correct performance, correct interpretation, and timely action. So the popularity of electronic fetal monitoring lies in certain very favorable factors. We need to do something beyond just auscultation, and it is perceived as an advance. The technological requirements are quite modest, cost that big, it's easy to use, and there's absolutely a complete lack of contraindications. Every pregnancy can be subjected to electronic fetal monitoring. And this, in fact, led to some unrealistic expectations in the EFM era. Now, this is a beautiful quote from Wagner in the editorial from the Lancet in 2000. And it says that today, that acceptance which women and families used to have is gradually reducing, and to a certain extent it's the medical system, I wouldn't say just doctors, but it's the medical system which has begun to promise perfection. So today when things go wrong, women and families feel that there was some negligence, they feel deceived, and they seek answers. Of course, we know that there's no system like that, and electronic fetal monitoring also has its drawbacks. Fetal heart variations may be from other causes. 9 out of 10 times, the distress pattern still turns out to be a false positive. There's a poor correlation between abnormal FHR, acidosis, and asphyxia. And sometimes it may happen that the severe fetal heart abnormalities that are seen in fetuses, you are already looking at a hypoxic acidotic fetus whom you may heroically do a C-section, but that fetus is actually beyond salvage. And this happens when there are additional factors. Say, for example, an infected premature fetus who has passed meconium, and there are changes in the electronic fetal heart rate monitoring. It's a very difficult situation. Now, where does the evidence lie? And this is from the Cochrane database. They looked at 13 RCTs with 18,000 women, both high and low risk labors. What they found is that electronic fetal heart rate monitoring results in a little higher risk of cesarean sections and operative vaginal deliveries. And this is inevitable because the moment we see something alarming, we are going to do some obstetric intervention. There's no difference in the APGAR scores, but they found that there is a reduction in the risk of neonatal seizures by half in the population which has electronic fetal monitoring versus intermittent auscultation. The conclusion of this Cochrane review was that, well, electronic fetal monitoring doesn't add anything much. But my question is, if there is a method which reduces the risk of neonatal seizures by half, the question I ask is, isn't that enough? Aren't we doing a great job if we are going to employ that method? So the next thing which we have to consider is risk management. And when we talk about risk management, a huge part is training. So unless you've got to interpret the data and take action, no sort of monitoring system is going to work. And today we have the facility of recording and storing the data. There are uniform criteria. There are clear guidelines which are going to be talked about in the subsequent talks by Dr. Umaram and Dr. Rathi. We take measures to see that the fetus is born in the best condition, and communication, which is very, very important, not only with the patient and her family, but amongst medical professionals too. So CTG monitoring should never be regarded as a substitute for good clinical observation and judgment, and neither is it an excuse for leaving the mother unattended during labor. This is the FIGO consensus bottom line from 2015, and I think it behooves us to understand that it's not just a method, it's the entire care package in labor which is important. So with that, I thank you for your kind attention, and it was a pleasure